there's a range of services and supports that are typically associated with systems of care. You see these on the list. Each of them can involve evidence-based approaches, specific evidence-based approaches, and also we want to emphasize the importance of natural supports. You will have these PowerPoint slides electronically, and you can look at them in detail on your own. But, as I mentioned before, we're focusing in on a core set of services now. And I'm not sure how many of you are familiar with a joint bulletin that was released by SAMHSA, the Substance Abuse and Mental Health Services Administration, and CMS, which is the federal Medicaid agency. And as a result of experience and some pilot work, particularly in looking at alternatives to residential treatment, we found that these are the services that emerged as particularly useful in keeping children in their homes and in their communities and out of PRTFs, psychiatric residential treatment facilities, PRTFs. Intensive care coordination using a wraparound approach, in-home behavioral health treatment, intensive mobile response and stabilization, peer support, all of those were already mentioned, and those are the ones that are emerging as some of the most critical services to have in your service array to help young people function better, again, in homes, in schools, in communities, to remain, as we call it, in home, at school, and out of trouble. Want to mention two of these, also two that I know you're working on in Ohio. One is mobile response and stabilization. You probably know that this involves mobile teams, usually a team of two, going out into the community, into homes, working with children and families in crisis, helping them to remain stabilized in their homes and communities. Also has been proven effective in keeping young people at home and out of inpatient and residential facilities. And the stabilization period can last from a very short time, and in some cases to a much longer period of time, to make sure that young people and families are then hooked up with the kinds of services and supports they need to help them remain stable in the communities over time. And it could be, for example, some of them 72 hours and some of them even longer. Peer support is another one that I think is particularly important, and you're going to hear that from some of our panel members about the value and importance of peer support. And here, these are families and youth who've lived experience. They've walked in those shoes, and they can help families and youth understand what they're going through, understand what the resources are, and provide them with the kind of support and education and skills training and advocacy that they need. They participate in child and family teams through the wraparound process. They are available to work, to come to, for example, IEP meetings in school, and to provide that kind of ongoing support that's helpful to children and families. So, just to sum up, what the system of care approach is not, it's not a model, not a program, and most important, it's not a treatment. It's not a clinical intervention. You can't have positive outcomes without having both an effective system and effective treatment interventions. And so I always try to emphasize that system change plus practice change is what creates improved outcomes, not one without the other. What is the system of care approach? It's an organizational framework, a value base, a guide. It has flexibility for states and communities to implement them in a way that makes most sense to their own environmental context. And as I mentioned, it can be adapted to the age group, to culturally diverse groups. So the idea is to retain flexibility for innovation, for adaptation, to the unique environments that you face in your communities and in your state. So what's different about how you work with children and families? What's different about this? And we have a very well-defined practice approach that I want to review with you very briefly. The practice approach relies on individual services that are coordinated, on family-driven, youth-guided, and cultural and linguistic competence. That's the practice approach. I'm going to talk to you just about a couple of them. First of all, you probably know that systems of care work generally with young people and families who are involved in multiple systems. We all share responsibility for these young children. It's not your child, it's not your child. In juvenile justice and child welfare and behavioral health, we all share responsibility for serving these young children, their families, and for the kinds of outcomes we may achieve. So intensive care coordination is critical to these kinds of situations to ensure that there's care coordination for the young person and also across systems at the child and family level. And these typically use the individualized wraparound process. And the wraparound process, you probably are familiar with this in some of your communities, but just to give a summary of it, it's a collaborative process. It's typically for children with the most complex needs. It did evolve in the 1980s, and it really has become one of the most important ways for operationalizing the system care approach at the child and family level. And it's evidence-based. We have more and more research behind it, and it takes an ecological perspective, focusing on the whole range of needs that a child and family may encounter. And this shows you the breadth of dimensions that are focused on in a wraparound process, not just behavioral health, not just child welfare, not just juvenile justice, not just education, not just developmental disabilities, but they looked at income, medical, legal, spiritual, all of the aspects of a family's life that they may be struggling with. And if we don't deal with those, then they may not be able to really focus on the behavioral health concerns. And what is the process? There's usually an intensive care coordination person. Sometimes we refer to this as a RAP facilitator. They convene a child and family team. It involves all of the persons involved with the child and family, with them at the center. And they develop a plan, an individualized plan. It includes all of the services and supports that they may need to address some of the areas that you saw in the previous slide. And they need to monitor progress, to adjust the plan as we move forward, and they monitor outcomes and see what needs to be changed to make sure that the process then reflects what it is the child and family need as they make progress and as their needs may shift over time. An important piece of this is that families and youth with lived experience provide peer support and advocate for these families and young people throughout the process. The other value that I'd like to talk about is family and youth driven. And I think there's two aspects to this. One, at the service delivery level, that families and youth are at the center of that process and they get to drive in full partnership with professionals what services they're going to receive, from whom, and how, and what are the goals they want to achieve. And that's really the crux of this process, that they know best about what it is they need, what their challenges are. And that should be where we start in our individualized service plans. And we find we engage families much better. We don't have resistance. We don't have non-compliance, because I think that really means services that don't meet the needs and aren't effective for them. So family and youth driven at both levels. And it requires a paradigm shift, and you probably all know that. It's a very different way of working with children and families, and it requires us as providers, as professionals, as administrators, and in all of our roles to think about how families and youth can drive their own services, their own care, and ultimately their own outcomes. Family movement has grown. You probably know that. We have family organizations, and we now have youth organizations across the country. The growth has been tremendous. Youth Move and such, and I'll mention that in a moment. But those have been vehicles really to try to push this value. I put the family-driven definition for you to look at later, and what it really says is families have a primary decision-making role in their own services and in services in their states, in their communities, and nationally as well. It's a definition of youth-guided services, and it's very similar. They should be empowered to be part and drive their treatment process, and also part of decision-making at the system level. So let me focus for a moment on what the the outcomes are of systems of care. It's all well and good to talk about this in theory, but what can it really achieve? What are we learning about this through now several decades of very, very robust research to try to determine what the outcomes are? In terms of effectiveness, it improves the lives of children, families, service. And let me give you a couple of examples. For children, we see decreased symptoms, suicide rates, and substance use. We see decreased arrest and less involvement in juvenile justice, increased stability of living situations. For families, they report that the caregiver strain of coping with their child's behavioral health issue is reduced. And interestingly enough, we see a lot of reports that they are able to work. They don't miss work as often because of the child's crisis, and they are better able to obtain and retain employment, which is important. And to improve services, we've seen that there's a broader array. We use individualized approaches. We use more care coordination, family-driven, cultural competent, and evidence-based, evidence-informed, evidence-based practices. So there are positive impacts we've seen, again, for children, for families, and for society in general, and the services that we provide as agencies. I mentioned before that we're focusing more on return on investment. And what that means is that we have been shifting resources from higher cost services to lower cost home and community-based services. And we have increased utilization of home and community-based services and decreased admissions in residential and hospital facilities. Not just hospital and residential treatment centers, but also detention, juvenile correction facilities, and out-of-school placements. And these have resulted in reduced costs across systems. Sometimes we look very narrowly at how we reduce costs in the behavioral health system, how we reduce costs in Medicaid. But we need to take a broader view. And the systems of care approach is reducing costs across all systems. So it's having a major impact in the short run and also over the long term. We now have a document that summarizes the areas in which we have been experiencing cost savings, and we also develop a guide. And if any of you are interested in that, a guide to evaluate your own ROI, in systems of care, we have a guide available to help you do that. Here are just a couple of examples, and these are federally funded systems of care. If you look at reducing inpatient, the average cost per child was reduced by 42%. If you look at reducing ER use, and that occurs, it's a finding we have, in that children who are served appropriately through systems of care don't go and present themselves to the ER as often. The average per cost child is reduced by 57%, arrests by 39%. By not dropping out of school, reduced school dropouts, a future projection of saved resources is really that 380 million could be saved, and that's based on a process of monetizing their future income and their future participation in taxes and so forth. So you can see that there are some real numbers behind this, and we can monetize some of the cost savings. And of course, it's a win-win scenario across agencies. I emphasized before that all of us are responsible for serving these young people and families, and of course many of them are seeing young people and families, and this offers alternatives to services with high costs. And I should mention that many of the high-cost services that we've used in the past have poor outcomes. The research behind them does not show that the outcomes achieved in these settings will be generalized to their homes, to their communities. For example, in residential treatment. So we're finding that intensive home and community-based services are often more effective and have outcomes that can be generalized and be sustained over time. What have we learned? We've learned a number of lessons in our time of system of care implementation, and I just want to highlight a few of the things that we have learned. One, system of care development is not a program, and it's not a project. I often bristle when I hear the terms project director and system of care project, because that's not what this is about. This is about system change. System changes can be maintained over the long run, can be sustained. Programs and projects cannot. So we have to look at this more broadly. The goal is sustainable system change. You don't need a federal grant to do this. The idea is to infuse and institutionalize the policies, the services, and the kinds of changes that you are implementing through perhaps a time-limited grant, but to figure out how those are going to be sustained over the long run. So the likelihood of sustaining and maintaining these efforts is reduced when you think about this as a 5-year or 4-year project. It's long-term system change. And you can tell that this is one I feel very passionate about, because I've done some research on sustainability, and it has shown that without system change and without projects that tend to be assigned in a particular agency and not part of the mainstream service system, those are the ones that are at risk for not being sustained and for going away after the funding and the project is completed. The other one that I feel passionately about is that system change has to be bidirectional. It's not enough for states to try to do this in isolation. It's not enough for communities to try to do this in isolation. It simply does not work. Systemic changes at the local level are needed, implementation efforts to actually put systems of care and the system of care approach in place, and systemic changes in policy, in financing, in workforce development are needed at the state level in order to support that. So they go hand in glove, and one without the other is not going to be sufficient. So this actually has led to changes in federal grants, and the changes are that states now are required to identify some implementation sites in their state that they're going to focus on. Some have done it statewide, and others focused on a few areas. And then communities that receive these grants also have to demonstrate how they're going to work with states to get the high-level systemic changes in policy and financing, et cetera, that we need to make these system changes that can be sustained over time. Roles of states and communities, there's a slide in here that you can look at, which really lays out some of the differences and some of the contributions that each make in this process, and you'll be able to see that in your copy. Another thing I want to mention is this concept of family and youth driven, which I've talked about early on as being a core value and fundamental to the work that we do. I'm repeating somebody who already said nothing about us without us, and I think that's an important thing to remember. And also that family and youth organizations can be key in trying to bring family and youth voice to the table at all of your discussions, at all of your meetings, at all your decision-making processes, about how your systems are going to be designed, about what services will be provided, about how they're going to be evaluated. And all of those major decisions about how you're going to proceed, family and youth voice are critical, and family organizations can help facilitate that process. And they fulfill, family and youth fulfill critical roles also in system of care development. And there's a slide here for you to look at also about what some of the roles are of families and youth. We did an analysis of this and really gave us some important information about how they can work together and what each brings to the table and what family voice can accomplish. I want to end with a note about recovery-oriented systems of care for youth with substance use disorders or co-occurring disorders, and I think this will be a nice segue to Allie, who will talk more in depth about this. And there has some history of focus in the behavioral health world at SAMHSA. The concept, I believe, was applied much more to adults than to youth and young adults, and there's a high prevalence of substance use in youth who receive behavioral health services, what 54 to 59%. We also see that 43% of youth who receive mental health services have co-occurring disorders, and that 46% of youth who have been served in systems of care have indicators of substance use also. So these are not different populations. These are the same young people and young adults that we're working with. And again, the importance of working together. Well, SAMHSA got together a panel several years ago, and they found that the system of care approach really provides some common ground and a basis for both to work together to create recovery-oriented systems of care. And they had several recommendations that I think are relevant for your work here. And I really applaud you for bringing these issues together in this summit. That this summit broadly involves the mental health folks, the substance use disorder folks, and from all other child-serving agencies, child welfare, juvenile justice, developmental disabilities, education. Forgive me if I'm leaving out something. But brings together all of those agencies and systems that have to work together, but particularly the two that make up behavioral health. Because together, mental health, substance use is behavioral health. And the panel recommended a few things. A range of individualized services that address multiple life domains. Sound familiar? If you were listening, that's what I was talking about before. Therapeutic and clinical interventions and recovery supports. And we always talk about services and supports, not just treatment, but treatment and support services, linkages and integration across substance use and mental health systems, and family and youth involvement. So very same core values and principles that I mentioned before. And I want to end by saying, and getting back to hear our voices, because you've heard my voice, but the most important voices for you to hear are the voices of young people and family members. They are the ones who need you. They are the ones who will receive your services, will hopefully benefit from them. They are the ones who will be your partners in determining what services they'll receive, from whom and how, and what goals they want to achieve, and how that will be monitored. And so I want to encourage you, as you proceed in your work, to hear their voices. So thank you, and I will turn this over to Allie.
And I just feel really honored that I get to speak after Beth. I got to have dinner with her last night and get to know her a little bit. And I really, she kind of made the comment that she gets to talk about systems of care kind of broadly and talking about systems of care, whereas I've kind of gotten to see it work down in Houston and where I'm from. And I'm just very fortunate that I've gotten the opportunity to work with some of the professionals that I have and some of the agencies that I've gotten to work in, with some of the families that I've gotten to work with. I have families that I've known for all 7 years of working in these systems of care because I've met them when they started treatment, and then I've gotten to work with them through the continuum of care, as they're transitioning to different levels of care. And so that's been, I think, one of the coolest things in the entire world is I literally got to see kids grow up into adults and be really fantastic, fabulous people and do really awesome things with their lives. So, this is why systems of care are so important. So I just wanted to start because I wasn't really sure kind of what everybody knew and that sort of thing. So whenever I give presentations, so I'm coming from the substance use world, but I also, work with other mental health issues and things of that nature. I went and got, because I got my chemical dependency license, and then I was like, well, most of these kids have another diagnosis. So I really wanted to be more helpful, so I went back to grad school and got more letters after my name, but, and more student loans. But just like what Beth said, I can sit in a room with a group full of kids, and I'm looking around, and usually, out of 10 kids, 7 to 9 have a co-occurring disorder, are seeking individual therapy, or going to an outpatient group for something other than substance use. So this is a very real thing. So I always like to ask, what's the difference between sobriety and recovery? Does anybody know? Behavior, okay. Mm-hmm. Anything else? Well, I'm going to tell you. So sobriety is abstinence from the mind-changing chemical, okay? The mind-altering substances. Recovery also incorporates abstinence from mind-altering substances, or abstinence from the self-destructive behavior, if that's something that you're looking at. So self-harming, eating disorders, these sorts of things. In the substance use world, we talk a lot about working the program, right? Now, depending on if you're coming from the 12-step model or a different model, really you can this utilizes a lot of the same aspects, whether you're doing 12-step or smart recovery, or CBT therapy, or DBT therapy, or whatever kind of acronym you're into that day. But working a program to me just simply means utilizing outside support. So you're reaching out, you're actively pursuing a different solution, because you've come to the realization that this solution isn't working for me anymore. Using the substance, using the self-harming behavior, or perhaps, in those 16-year-old cases, you haven't determined there's a problem, somebody else has determined there's a problem. Your mom, or a judge, or school teacher, or something like that. So, recovery is actively pursuing a different solution to your issue. And so this is the definition from SAMHSA, from NIDA. It's the working definition for recovery. And I underlined, highlighted, italicized the process, because that's what this is. That this is a process, meaning that you don't arrive at recovery. It's kind of a constant, we talked about substance use and other mental health disorders being chronic and progressive. And fatal, and these are the types of words that we use when we're describing these things. And so, shouldn't recovery also be a process that addresses this chronic, progressive, type of disorder? So, I don't want to spend too much time on this, just because I'm going to have a group on Saturday. So, if you'd like to find out more information about alternative peer groups, then Saturday come to my seminar. Okay. Otherwise, I'm going to get super awkward up here. Okay, so an alternative peer group incorporates a whole bunch of different things. It's community-based, it's family-centered, it's staffed professionally, it utilizes positive peer support. So we hear a lot about, negative peer pressure, right, or peer pressure. Well, we took something that's very naturally occurring with young people and we put a positive spin on it. So if we can have negative peer pressure, then we can have positive peer pressure. And honestly, that makes it a whole lot more easy to come to work, because if you've got a group of kids who are all coming there for the same purpose, which is to recover and to find a different solution to their issues, then you can it is a beautiful thing, y'all, when you can kick back and you can watch, and you said something to this kid 20,000 times until you're blue in the face, of like, maybe you shouldn't hang out with that guy. That guy used to sell you drugs. Maybe that's why you keep getting high. Don't go down that street anymore, you know? And then Joe over there says the exact same thing in a group to this kid, and the kid comes to you and is like, oh my gosh, I shouldn't go see Kevin anymore because Kevin used to give me drugs. In fact, I think maybe I should just not go to that neighborhood anymore. And you're like, oh, that's great. I'm really glad that Joe told you that and they figured that out. And this is how positive peer support works. And this makes it so much easier because, you know, as we all know, burnout is a real thing. And when you're working with these kids and you're saying it over and over and over and over all day long, that can get really exhausting. So let them work on each other. It's a beautiful, beautiful thing. And as we also all know, if you've ever, I'm not good at math, so if ever I have to try and teach math to somebody, I end up learning it better because I have to break it down, I have to slow it down, I have to say it in different ways in order to teach somebody. And so whenever I'm doing that, I'm learning it even more so. And so by giving our kids the opportunity to work on each other, they're actually internalizing it more. So they're taking the solution that they've gotten, and I don't have to keep repeating it to them because now I get to stick them on the new people, and then they get to break it down and slow it down and teach it, and then they learn it better. And they'll come to me, oh, I'm so frustrated because that person keeps going to Kevin's house. And, you know, sorry, anybody who's is Kevin out here. But, you know, and I'm like, what are you going to, you know, do you remember what it was like when you were there? And they're like, I was never like that. Bullshit, but okay. You know, and so you get to kind of work with them about how to deal. Then you have a growth opportunity right there, you know, of how do I deal with difficult people? How do I deal with frustrating circumstances? Okay, I said I wasn't going to spend a lot of time on this, and now I am. But, so if you look at alternative peer groups, this is for substance use, self-destructive behaviors, or other mental health issues. And although it started, the APG movement started due to substance use disorder, it is now moved to incorporate because we've just seen that most of the kids who are showing up on our group also have mental health issues, period. So whether we're saying that we're doing that or not, we are. Let's just jump on board. So if you take a look at this graphic right here, I'm not going to talk about it too much, but I did want to show it to you so that you could see an alternative peer group kind of incorporates all of these different tools. So to me, the most important tools in here are the family support, the community recovery meetings, and the social functions. And of course, as the adults in the room who are the caregivers, we're like, not the case management, not the psychosocial education, not the counseling. No. The meetings are really important because again, that's where the kids get to work on each other. The social functions are really important because that's where the kids get to bond and have fun with each other. They smile. They're excited about being there. We had a function at Palmer Drug Abuse Program, which is the original APG in Houston, and we called it Dope Fiend Olympics. And it was basically like kind of fear factor and the minute to win it challenges and stuff like that, all kind of wrapped into one. So they ate gross things, and they did weird stuff. They got on a slip and slide covered in baby oil, and they had to do the wheelbarrow, you know, where somebody like holds their. It's hilarious. So. The social functions are really important because if the kids aren't having fun sober or away from their self-destructive behaviors, they're not going to continue to show up, period. It's got to be fun. It has to be. So that's really, really important. The other stuff is important too, obviously, but for the kids, when you're coming from the kids' perspective, the stuff that's going to draw them there, the stuff that's going to keep them there, is that stuff, is friends and fun. And then you need the family support, because otherwise you're just putting a really healthy kid in the car with some very sick parents who are going to undo all that good work you just did. So I wanted to touch on this too, just the definition for Recovery High School and the goals of a Recovery High School. I just want to acknowledge the fact that Recovery High Schools also look at substance use disorders and learning disorders. And can in fact offer services the exact same services for both, and we're going to get to that in just a second. Okay, so as I've kind of already been saying, we use the same tools a lot of times for both, in APGs and recovery high schools. We use peer support groups, which just offers them a safe place to talk about what's going on. So one thing I do want to mention is, for those of you who are in substance use, we kind of talk about how the eliminating the drink or the drug is the very first part, right? Once that's done with, once we learn how to quit, once we get a little time, quitting the drug or the drink, the real work starts, because there was a whole bunch of stuff that was either causing us to use in the first place, or that we were kind of continuing in a shame spiral, right? We would drink and get high because it was fun, and then we would do stupid stuff, and then we would get in trouble or feel shame and guilt, and then we would drink and use, in order to, and same with so many other self-destructive behaviors, right? It's that same shame cycle. So, by offering a place, a peer support group, for them to just be able to talk about all of the day-to-day stuff that comes up for them, all of the stuff that they're struggling with, they're entertaining thoughts of going back to that solution, to the drug or the drink or the self-harming or the eating disorder or whatever, or the impulsivity or the risky sexual behavior or the stealing or the, you name it, they'll do it because it changes how they feel, or it can help them control how they feel. And so it gives them a place to just verbalize that, to talk about it, and to have other people sitting in the same room going, yeah, me too. Yeah, me too. Here's what I did. Hey, remember how that didn't work out for you the last time? Maybe you should try something different. Come hang out with me instead. Let's have a guys' night. Let's have a girls' night. So that peer support group can be used for mental health and substance use. The pro-social activities I've already kind of talked about, promoting those social skills and bonding, who are going through similar issues. Oh, also, they are going to work out so many things with the peer-to-peer contact. Because all that stuff they're going through at school with teachers, all that stuff they're going through at home with parents, all that stuff they're going through in their own minds is going to come out in their social interaction. And so this just gives us ample opportunities for learning and for growth and for teaching how to deal with other people and what that means about them and how to deal with themselves in relation to other people. So then there's the clinical components of skill building and guidance. Well, the skill building could be in counseling sessions, that could be in workshops, that could be in individual sessions and things like that. And then also just helping the families get guidance to other resources. So if there's something that the APG or the recovery high school cannot provide, they can have a resource list and they can help make that bridge from the APG to the other resource. So if the kid is really struggling with eating disorders and that's not something that the APG counselor is like really in their scope of practice, or they don't feel like they're able to really hone in and focus with that kid on helping them get through that kind of initial crisis time, then they can refer them to either a facility or another provider and make that bridge. So here's what I do. We will call them together and put them on speakerphone. And I'm like, hey, Becca, I know you really specialize in DBT for eating disorders. I've got a family sitting with me right now that they would like to talk to you about how to utilize your services and how we can work together. And then we have that conversation all together with the new provider. And I want to make sure and stay in contact with you in order to, so will you let me know what y'all are working on in your individual sessions so that we can help out here when they're showing up to our groups and when they're showing up to our functions. And that's how that system of care can work, working together. So the parent support, super, super important to get the parents in there. I always tell the new parents, I'm like, you can't do drive-by. You don't get to just drive by, push your kid out of the car and say, here, go get fixed, and then keep driving. You have to come in. You have to come in. Come and talk to us. We're okay. Because really, really all of the stuff that the kid is saying, right? I don't want to, I don't know those people, they're weird. The parents all think too. And so you've got really, you're sitting there with a bunch of kids in the room, even though you're sitting there with some adults. So inviting the parents to come in, and the parents need to have their own social functions. They need to have their own ice cream socials, dinners, they need to go do stuff with each other. I had a big group of dads, and they all would go to baseball games because all the dads were liking baseball at the time. So they would all get tickets and go to baseball games together. All the moms would get together and go do mom stuff. And, and so the parents need to form those functions as well. Oh my gosh, we're at 10 minutes at the end of that. Woo-hoo, okay. Continuous care, communication, which I already kind of talked about. We're going to just kind of ride on through some of these. Okay, so APGs and recovery high schools work together. I'm going to skip a little bit and just tell you a story about a kid. We'll call him Nick. Nick went to a behavioral health facility for self-harm, suicidal ideation, severe depression when Nick was 15 years old. His parents didn't want to send him back to school, and weren't really sure. They didn't want to homeschool him because they both had to work, and so they don't want to keep him at home, with kitchen knives and things like that, and risk him self-harming. And if you're depressed and you have a hard time getting out of bed, staying at home isolated from others probably isn't going to be a super great solution for you anyway. So Nick got involved in an alternative peer group. He had never used substances before. He was strictly there for self-harm, suicidal ideation, and severe depression. Nick also, because it was a 12-step group, Nick got a sponsor. Nick worked the steps. Nick passed it on to other kids. And also went to the recovery high school because he needed a place where they were going to therapeutically help him when he was really struggling. And they had people who knew to look at his arms and who knew to check in with him when he had his head down and his headphones on, was in a corner with a hoodie up, and they were like, hey, how are you? We see you. What's going on? What do you need? Do you need to go take a walk? Do you need to go have a one-on-one with another peer? So, how APGs and recovery high schools work together is they communicate with each other. So the kid gets to be at school for 40 hours a week, right? And then the recovery high school needs to communicate with the alternative peer group, hey, this is how he's showing up at school. And then the alternative peer group can communicate with the recovery high school, or this is how he's showing up here. Because here's what happens. A lot of times a kid is a total rock star at school, making good grades, really, good kid in class, what I call it. But then they're showing up at their APG and they don't want to be involved, and they're talking back to the staff and all of this other stuff, or vice versa. A lot of times it's vice versa. Usually the kid is showing up at their APG like a leader, a rock star, and they're goofing off in class and getting in trouble a whole bunch. So when we talk to each other, then we can get a more full picture about what's going on with this kid. Okay, so if you're being a leader at your alternative peer group, but you're acting up in class, then we know you have it in you, basically. And so how can we, do you need to have a leader position in school in order for you to feel the same about stepping up? Okay, I'm just gonna rock and roll. Okay, this is a really awesome graphic about how somebody can start on any part of this continuum of care. So I've had kids from out of state. I had like 5 kids from out of state. Their parents sent them to Texas to go to treatment, live in sober living because they were 17, which in Texas that's kind of a weird age. Like sometimes they're an adult, sometimes they're not an adult. But they were living in sober living. They were going to the recovery high school, and they were going to the alternative peer group. And sometimes the alternative peer group is where people first show up, and that's okay. It's the lowest level of care, but we can start there. And then if you need to move up, fine. If you don't, great. We didn't have to utilize those services. We could just bypass the whole treatment thing altogether, and you've got your peer support group. Okay, so here's what I really want to talk about. The key ingredients for successful adolescent systems of care. Y'all gotta know each other. You've gotta know who who each other are, you've got to know your programs, you need to have relationships, go to lunch, invite each other's fundraisers, be involved in each other's programs, support each other's programs, love each other's programs. And I'm going to get to why. Communicate with each other daily, almost daily, or at least weekly. If you're sharing a kid, there needs to be that communication constantly. Okay, humility. This is a really big one. Okay, this is what all of y'all can do today. This is what all of y'all can literally walk out the door and start putting into practice now. This is how you can facilitate systems of care happening now with you. And that is being humble. And internalizing that we are all on the same team. Our mission is to help kids live successfully, happy, healthy lives. That's like all of our missions right there, and to help those families, right? And we all have different flavors. Thank God. Thank God, because not everybody recovers the same, right? People recover differently. Different stuff works for different people. And sometimes, just like me talking about Kevin the dope dealer, you know, they might not be able to hear it from me, or my approach might not work. But guess what? I know somebody who might really click with you. Let me shoot you over there, and why don't you give their program a try? Because maybe we've tried it, and you know, there's been relapses, and there's all kinds of stuff going on. It's just not really working. Okay, maybe I can refer you over here, and you can get it in their program, because they've got a little bit of a different take on things. We need to speak kindly about each other's programs, even if we don't agree. We need to shut down shit talking. I knew I was going to curse at least once up here. And that is, and this is something that Houston's really grown from, is we need to shut down shit talking from the kids, okay? We need to shut down the shit talking from our staff and from ourselves. We need to make sure that we're speaking kindly about other people's programs and we're building them up. Because thank God we have so many other programs that we can refer to. What a blessing. And be open. So this is something that Houston has really, really had to work on, but we just don't hoard information that works. If somebody emails, you know, one of us in the community and they're like, hey, I'm trying to put together a new intake form, can I have a copy of yours just to see what it looks like? And, you know, hey, can I even use it? Yeah, whoop, there you go, take it. Why? Because we're all on the same team. We're all doing the same stuff. And let me tell you what, there is no shortage of sick kids. There's just not. Unfortunately, I will always have a job. Unfortunately, we will always have a job. There is no shortage. We can continue to help other people, always and forever. So if we're coming from this place of like fear, of lack, then obviously I watched The Secret, done. Catch that. But, you know, if we're coming from this place of, well, I can't refer to them, I've got to do this, then we're not doing a service to our kids, we're not doing a service to ourselves, we're not doing a service to our staff. My mission is to help the kids, however that looks. Okay, so does it really work? Duh, yes. So I wanted to show pictures because this always helps me learn. But this is both of the executive directors of 2 different recovery high schools in Houston. This is both of our staff. This is APG staff from several different programs and a couple of parents thrown in there as well. So, and as you can see, we're all very happy to be together. We went to the Facing Addiction rally in Washington, D.C. It was really awesome. It was like a 24-hour turnaround. We were exhausted after all that. It was super fun. This is Recovery in the Park, which is an AROS put on our AROS, which is Adolescent Recovery Oriented Systems of Care. Puts this on every year. It's been going on for 3 or 4 years. I'm going to wrap it up real quick. Hold on. And so all of the treatment centers, all of the APGs, all of the recovery high schools, if you have something to do with adolescents in recovery, come to the park and hang out. We have an ice cream truck, we have a DJ that always sucks for some reason. We play touch football. I mean, we have a really great time with each other. And this is just a time for us, again, to get to know each other, to know who we are and our programs are. This right here is Prom, or Sober Prom. And it's put on by both of the recovery high schools. And so both of the recovery high schools go to this because they're rather small. And so this way, you know, it's not just like 10 people awkwardly dancing. It's like 20 people awkwardly dancing. But, and then all of the APGs come, and that's the function for the evening. And so all the kids get dressed up, they, you know, take limos there, they go out to eat after, all of this other stuff, and it's super fun. So I just wanted to just show you that this stuff works, that collaborating with each other works. So here are some awesome resources. If you want to find out more about alternative peer groups, if you want all of that beautiful information given to you, because there's people in Houston that have done it the hard way, don't reinvent the wheel. If you go to apg-recovery.com, you can email them, and I believe you have to join, but it's really, really cheap to do that, and they will send you all kinds of awesome information. The Recovering High School's information up there, the Leisure Recovery information is up there, and then of course, please come and watch the Generation Down documentary that's going to be shown tonight. But it's about the Houston adolescent recovery community. So you're going to get to see it. All right, how did I do on time? Okay, so I would like to invite our beautiful panelists up here. Because the thing is you can hear it from me, but you're really going to hear it from them. You're going to hear about what worked for them, what didn't work for them, and what they would like to see. And I got to meet them last night, and they really just inspired me, whichever order you go. But anyway, so I want to just introduce briefly, and then they're going to get to introduce themselves. Matt, Dana, Taylor, and Heather. And in just a few minutes, they're going to kind of tell a little bit more about what brought them here.
Well, I'm going to start this off and first ask each of the panel members to spend about 2 minutes talking a little bit about their story and to share what the impact of mental health and substance use challenges had on their lives and those of their family. So let's start with Matt.
Well, let's start with the biggest thing for me was challenges, especially when not having the support as a younger youth, and really had to push it as I was older, and eventually it got to where I was they helped.
Matt, can you tell us a little bit about your history briefly?
Yes, I grew up in foster care, living poor, was bouncing around multiple places, and then finally went to Boy Scout during my sophomore year of high school and graduated from there. Was homeless after that for 3 years, off and on, and then got in daybreak in Montgomery County, and have since then had a daughter and been doing well.
Hi, I'm Dana. I am the mother of residential children from age 4 to teenagers. One of our child has bipolar and ADHD, so we have mental health navigated that. In 2009, our daughter was born unexpected with Down syndrome, so that's been a whole new adventure that we're handling.
So a little bit about me. My name is Taylor Stevenson. I was born and raised in the Columbus, Ohio area. So my first experience with kind of diving into substance abuse issues for myself kind of started at the age of 14 for me. By the age of 15, I was a full-blown heroin addict. A lot of my initial use was driven by a lack of self-worth, which is something that I really try to place emphasis on today. My addiction, it wasn't something that progressed slowly. It was something that kind of just came along right away for me. Something I kind of just dove right into. And because of that, it didn't take me very long to get to the point where I was willing to do whatever to get whatever. by the age of 17, I was fully into lying and stealing. I didn't take very long after that I was introduced into sex work, which ultimately led to, really being into the depths of human trafficking. It wasn't until the age of 21 for me that I found out that I was pregnant with my now beautiful son. And, during that whole time of unknowingly being pregnant, I was in the depths of being out on the street, for quite some time, living in abandoned houses. I was 105 pounds soaking wet, barely getting a meal in a day, and here I was, by the grace of God, with this perfectly healthy baby boy who was about 4 months along. And, something just kind of clicked for me at that moment. So I really had to open myself up to a new way of thinking. Something that was introduced to me was kind of getting into COMPRA, which is a local medicated assisted treatment center here in Columbus. And it's something that I lacked a lot of knowledge on and therefore had a lot of big opinions on it. And to my surprise, it played a major role in, continuing to save my life today. I was introduced to a group of people who have played such a large part in creating a foundation for me today. So that's something I definitely try to pass along.
Thank you. And Heather.
Hi, first off, thank you for being here. My son's substance use started when he was a freshman in high school. Started with marijuana and pills, and over the course of the next couple of years, progressed to intravenous heroin use. Throughout those years, he spent time in residential treatment centers, intensive outpatient programs, seeing mental health providers, running with the justice system, emergency room visits. The biggest challenge for me early on was accepting that I could not fix my son, and I had to look elsewhere so I could provide him the tools he needed towards his own recovery. I didn't expect the challenge of finding timely and affordable care. So that was the next hurdle. Also, it's often said addiction is a family disease, so it was important for me to find treatment for myself too. And with the support of other families who had gone through this before, I was better able to support my son, not only in active addiction, but in remission as well.
So we will kick off asking some of these questions. So Heather, I would like to know, what has been your experience with finding treatment and supports in your home community?
The residential treatment was the biggest challenge. Finding an adolescent dual diagnosis program was very hard. I'm also from Columbus. And at the time, my son was hospitalized for drug-related issues, and we needed to get him into a higher level of care, which at that time would have been residential. Resources were very scarce in the area, and then you're supposed to go where your insurance wants you to go to, which was nearly impossible, but we'll save that for another conference. So what ended up happening, there was a lot of waits, 2 to 6 weeks of a wait list, and anyone who's been in that position before knows that time is a luxury you don't usually have. So at 15 years old, my son went to a residential treatment center in Pennsylvania, about 8 hours away, because they were able to get him in right away. He spent 90 days there that first time he went. So getting access to care locally in a timely manner was definitely difficult.
And so Dan, can you speak to the particular challenges you had in finding services in your more rural area?
Yes, I live in a very rural county. Literally, our graduating class has 60 people. We were in early intervention for our daughter. Our service coordinator put a referral in for us to get an evaluation for OT, PT, and speech. Upon contacting the one service provider in the county, there was 102 wait list just to do an evaluation. They told us that she probably wouldn't be evaluated until she was 7 or 8. That was unacceptable, so we drove 2 hours twice a week to a metropolitan area so she could get services. It's just a very lack of services.
And that's one of the reasons why one of the services we're focusing now is intensive home-based treatment.
Does not exist.
And trying to find out what are the key elements of that, how it can be paid for, and how states might look at implementing that as a service, which would be one of the solutions for providing care in rural areas. The next question is about co-occurring disorders, and Heather, you already touched on this, but of course we know that some families have issues with co-occurring conditions, and I wonder what the challenges specifically have been around finding services for that, whether it's mental health and substance use conditions or mental health and developmental disabilities. So Taylor, would you be willing to start responding to that issue?
Yeah, so for me, dealing with co-occurring disorders was definitely a part of my journey. And it was something that not only myself, but my family at the time, being so young, had quite a difficult time navigating. And more so just kind of trying to grasp an understanding of what co-occurring disorders were to begin with. It was something that was kind of unheard of, you know, on my side of the family for quite some time. So there was a lot of lack of access, trying to find a certain service or program that specialized in co-occurring disorders. And unfortunately, that kind of set the stage for myself and my loved ones to kind of have a lack of knowledge about it. And that kind of led to me only focusing on joining programs that were geared towards my substance abuse issues. And, you know, I kind of had to put my emotional trauma, my sexual trauma, all of that kind of went on the back burner, you know, because although it was suggested that these things kind of, you know, get focused on, you know, that I dive into counseling, no concrete information was given to us. You know, we weren't really sat down and kind of mapped out like what to do next. Here is the first step, you know, so that definitely made it difficult.
Great, thank you. And I think that Dana, you were also going to address this issue.
Yes, it was very difficult for our son, since he already had the mental health diagnosis, when he started to experiment with substance abuse. Trying to find him treatment was almost impossible because the treatment centers would not accept him because he had a mental health diagnosis. So he was in active issues with his mental health. They were just saying, no, he needs to get mental health treatment before they could help him with substance abuse. Substance abuse providers were saying, no, he had to get help for his substance abuse before the mental health providers would help him. So it was just everywhere you turned, they were saying, no, we can't help them until they fix this. We need to fix both at the same time. Like I said, and treatments for 2.5 hours, 3 hours away. There's nothing in our community.
I want to go back to a previous question, and I know there's a workshop on this in the program in terms of rural areas. Telehealth services are now being used increasingly to try to bring consultation and services to areas, rural areas, frontier areas that don't have professionals and programs in place. And that's one of the solutions to what we talked about previously with access. And so I wanted to suggest that if any of you are working, particularly in rural areas, that workshop might be a good one to attend.
So this question is kind of for the young people. So what types of services and supports have been the most helpful that have really made a difference for you? Matt, would you like to go first?
I would say the most helpful thing that was provided for me very fortunate and lucky to be able to have this, but I had a consistency of case managers, and that was there for me, and I looked at them as my family, as my guidance, because I didn't have parents in my life at that time. In fact, I didn't meet my mom until I was after my senior year of high school, after I graduated, so I was 19. And so just the consistency of caseworkers and case management working together instead of not working together even after I had already emancipated from children's services, and referrals that were made for me to be able to step up and show that leadership and how it has helped me.
Yeah, so for me, like I had stated before, kind of diving into the environment of comp drug was the one service that really played a big part for me. For an addict like myself, it was something that provided ongoing structure for me and provided a sense of a foundation that was kind of mapped out for me and with me. That's what was most important for me. So one thing that I found really helpful about comp drug structure is the way that everything is pretty much provided under one roof. And for myself, it made it so much more attainable for me to actually take advantage of those services that were being offered. Comp drug, they provide everything from a women's clinic to dealing with trauma hands-on, which is something that, if it wasn't right there, I probably wouldn't have taken advantage of it. It was something that was really fear-based for me. And then also, it really gave me the opportunity to start establishing relationships with other women. And not just that, but establishing a sense of trust with others and a sense of trust in the system. It was something that, gave me the opportunity to take advantage of other services, even if they weren't offered there, due to the fact that there was always going to be someone right there to work alongside me. I always had somebody that was geared towards whether it was my trauma or trying to find services for my son at the time, or trying to help me out with, getting back into school full time. And 4 years down the road today, it's certainly helped out. I've gotten back into school. I'm about to graduate with a degree in social work. Thank you. And I now have, 2 months ago, we just gave birth to another beautiful baby girl. And so I'm able to provide for them because of services like that. And I was able to definitely take control of my life in the way that I wanted to. And if it wasn't for the relationships being sustained over these 4 years with people that I genuinely trusted, I probably wouldn't be where I'm at today.
And sustained relationships with other people.
Yeah.
So follow-up questions briefly. What is a service that you feel like would be most helpful that isn't readily accessible or available to youth and families?
Yes, I would say a big one is just the reiteration in school teachings. I know a lot of the times it's more push for a class versus the training for teachers and for the family to be able to understand and see and incorporate how it affects the youth in many ways. And I would say the other thing would be just the stability of working with each other. Like I said, I was very fortunate to have a small community that was willing to work together to support me. But there's many communities that are not like that. They're a lot bigger, they don't have the people to come together, and it just makes everything so much harder because they don't communicate.
I'm listening to all the different things that my name first down, first thing, is there about the purposes with and I'm sure we all have a story. But my question is, great opportunities
certified county. So there is, but there isn't.
Okay, well, here's the reason I'm bringing this up, is I have a lady here that has no clerk in this town. And the reason that I'm bringing this up is I have been on. I've been with Dining County, and our services, we have an admin board, and I also have a nanny in Dining County. I'm like parent advocate for my child, who's 35. My circumstance is different. We didn't have the opportunity to give him help with doing the adult. He had his own right to do this. Someone without education, right over schizophrenia, that does not have any sense of well-being or going on for himself. I could not get any help because of that. I have been regarded. Now, with that being said, he is right now in Hartford recovering because he had to get police involved. Having to be police, but he was arrested. Long story short, father and I decided he doesn't do what he has done in the house. He is not part of it. So we're a hunting family. To give you background, safety is always first. So because he was not able to get his medication, he didn't want to. He wasn't able to. He was on them, he was found a job, he was a disability, and as a result, Medicare canceled him because he couldn't stay on them because he made too much money. His job offered him insurance, but it was within 30 days and he thought it was better, so he missed the deadline. As a result of those meds, he lost touch with him. So now I'm here because I'm not the only one. So this directory that I'm referring to would be a great resource for someone like this woman here and myself to bring into our house.
It sounds like you brought up, and thank you for sharing that, some of the very same issues that we are addressing with the panel. It's what happens when services are not available, when we don't know about them, how you can find a continuing range of services that you and your child may need. I'd like to continue with the panel because I think some of these issues.
You would have the opportunity to give us what you think some of the next steps should be. So that they can get through this, but we're gonna have it, when you're gonna take a poll.
You're going to take a poll and tell us what you think some of the next steps should be, okay?
And I think it's very interesting that, of course, what you're raising are some of the same issues that we discussed with our panel and some of the points that they'd like to make. Because I think they're speaking not just for themselves, but for the collective group of youth and families that are experiencing very similar issues and challenges in getting the kinds of services that they need. I do want to go back again. I keep getting back to the co-occurring question because I wanted to point out that there's another workshop on this that deals with the integrated co-occurring treatment model, which was developed right here in Ohio and now has an evidence base behind it and is one treatment approach, evidence-informed treatment, that is proven to be very effective with young people who have both. I want to move into the area of peer support. We've talked a lot of peer support. I have, so has Allie. And so I'd like to ask whether you have received peer support, and if so, what is the value and importance of that, particularly for other young people and their families? And by peer support, I mean parent peer support and peer support for youth and young adults. So we are going to start with Dana.
Yes, I accessed parent peer support. So with our son, we kind of did that on our own, and we survived it. With our daughter, it was a whole new world that I was not prepared for, and I was exhausted because she was our fourth kid. We had 3 other chaoses going on in that household. So when we started down our journey and our path, and like I said, when our service coordinator for early intervention told us that she put a referral in to get us evaluated, but we were 103, and they weren't even doing 1 evaluation a week. I was like, oh, no, that is not going to happen for our house. So we also lived in a county where our county board of DD, a consultant came in and told them that they were not responsible for EI, so if they chose to drop it, they could. So 2 weeks later, they walked away from EI. Being that only service, no questions.
What is the,
Early intervention, sorry. So I was at a breaking point. I knew that early intervention was a mandate that my county needed to provide in some way, shape, or form. I started doing research. I got in touch with one of our friends who happened to be a county commissioner. He told me about this Family and Children First Council. I went in there, not very polite, not very nice. I was just an angry, exhausted mother. They kindly put me in service coordination, offered me a parent-peer supporter, who was a very kind gentleman who calmed me down and said, look, we can get through this. We've done it. Let's go back the right way. Don't come in here like a crazy lady. Relax and we'll fix this. It was just nice to have somebody else who has been through a similar situation who said, it will be okay. You can get through this. You will live. Your family will survive. The nuclear bomb has not dropped.
So someone who's walked in your shoes, who can mentor you, support you,
Yes.
advocate for you
Yes,
is really
and
critical.
teach me how the systems
And
work and
teach you.
how to approach the systems and how to work with a team, not just go through the motions.
Taylor?
Yeah, so for myself, peer support is something that I deeply value, and mostly because I lacked it in my youth years, and it's something that I've been able to gain throughout my young adult years, and I've also been able to, give back to others. One of the services of peer support that I was first introduced to was Catch Court, and being involved in that and being able to work one-on-one with a woman who has been, in my shoes, who has walked that same pathway, that did a great deal for me. Those women, they taught me, not just with the physical trauma, but with growing up with the emotional trauma, the mental trauma, because it comes in all shapes and forms, and that's something that I really had to realize. Those women, they taught me that, the human trafficking, the rape, it wasn't just a part of my history, it was now a part of my identity, and I have absolutely no shame in saying that today. And that's largely because of the peer support that I was able to receive. And on the other end of it, I've gotten the opportunity to work alongside SafePoint, the local needle access program here in Columbus, and being able to give that peer support back to somebody who's in active addiction, being able to see how far they've come just within the couple years that SafePoint has been open, it's been such a great opportunity to see that, to see just how far someone's come. I'm able to sit down with someone and actually get honest, and actually provide a sense of empathy, something that I never thought I'd be able to gain. So it truly is something that's impactful.
Thank you.
So, many people who are at this summit today are working in different systems, such as education, the juvenile justice system, developmental disabilities, addiction, and physical health services. So in your experience, and this is kind of for Matt and Heather, in your experience, how well do these systems communicate and coordinate with each other? And what do you think these systems could do better to be more effective with mental health and substance use challenges? Yeah.
I would say, for me, they worked pretty well, but I was also in a smaller community. A lot of the other kids that I went to school with were at Boys Town, and they did not have that fortune of support. They had it from Boys Town as a community, but from the juvenile justice system, their counties, their state, it was very, very different. I would say that the biggest thing they lacked was the communication and understanding between each other, that they could work together and figure out that it wasn't just the juvenile justice and mental health, that it was one portion that could work together, and that really would have helped. And then the mental health inside of that was not just a mental health issue. You know, that's something that youth need help with, and just understanding that where they were coming from and what they were asking for. Because a lot of times it's hard for somebody with mental health or with an addiction problem to really come out and say what they really need help with. And when they do, they're so nervous or scared about it that they don't come off the right way sometimes.
Yeah, I wanted to touch on the positive aspect of when systems of care are actually working well together. I was able to experience that with my son between his public school system and his residential treatment programs. The public school was able to offer him an online platform to complete his classwork while he was in treatment. So he was able to log onto a computer at treatment and do his classwork. There was a teacher here that would communicate with the teacher there about the progress he was making. The counselor at the school also was able to talk to the counselor at the treatment center about his progress. So when he came back to school, there was a smooth transition. When he did get out of residential treatment, the school set up a reentry meeting. So before he had to go back for his first day, we went in for a meeting. They developed a Section 504 plan for him, which is used for people with substance use disorders or mental health disorders. And there was things listed on there like he was allowed to use a stress ball for his anxiety. He was able to identify resource people in the school that he could go to if he was struggling. We also had a drug and alcohol interventionist within the district, so she was used as a resource as well. He was able to continue counseling during school with the school counselor, not the academic counselor. During, when he returned, they also offered a coping skills group he was able to go to during the day. They also have a alternative high school he was given the option to do, which is smaller classes, more one-on-one care, and more mental health services available to him. So it was nice to see the fluidity between when the systems do work together, because it was probably the smoothest thing that's happened along the journey, and it just relieved a lot of pressure, I think, for my son returning to school. And the school was on board with everything, very compassionate and considerate to him and his needs returning.
How many of you have experienced the child family team process through REP? Not very many. That process represents an opportunity to bring together the youth and family with an intensive care coordinator and with all involved professionals from all relevant systems. So a school representative, a therapist, somebody from criminal justice or child welfare, if they're involved, and some other individuals that a family might identify. And that provides a structure where these involved professionals and family youth and other individuals that are part of their support system can come together and collaboratively do some of the things that you mentioned in a more structured way. I think the wraparound process, the intensive care coordination with wraparound is a way to really improve the coordination and collaboration of all of the involved systems on the level of the child and family. I also wanted to look at how you think schools can improve what it is they're doing to help youth and families. We're hearing a couple of examples of how that worked well. What can schools in general, can the education system do to better address the needs of young people who have mental health or substance use challenges? Heather, Matt?
I would say one thing that would help anybody as far as youth goes in that case would be just integrate, like I touched on it earlier, but it would be integrating it and training the teachers, not making it a class, but training them on how it affects the youth, how it affects the families, how it affects their peers, and how to handle and train them to integrate it into the program. So that way, the kids will learn from that. They don't look at it as a punishment or anything like that, versus if you put them in just a class, they think that they're in trouble. And so they don't want to be there. But if you integrate it into the program for the class, it makes it to where the kids not only learn from it, but they teach each other. Outside of those classes, outside of the school, in the community, and it's one of the things that you can use every day.
I was just going to add, I think a big way to help is talk about it more. So it's not, we're not waiting till there's a problem. We talk about it with kids who have substance use and mental health disorders, and also kids who don't have those things. So people are going to try to get help more freely, let go of that stigma a little bit. I'd asked my son about that, like what was the single thing you wish could have been different, like during high school, to support your recovery. And to piggyback on what Dana and Matt had talked about, is that he mentioned peer groups. He wishes so badly he could have been with other people his age who were in recovery also, and that just wasn't available to him. So I think even within districts or counties working together to get kids from high schools together who are in recovery would be really beneficial.
Do either of you have any comments about how schools do a better job of working with young people with these challenges?
Yeah, just to kind of like piggyback on what Matt said, because he brought up a really good point with integrating it into the educational system. One way that like I wish I would have seen that happen, and maybe this is guided towards, male and female at a young age. Being able to touch on the everyday struggles that youth deals with. So for me, I know it was a lot of unhealthy family dynamics that were going on that I didn't know how to talk about, that I didn't know how to bring up. A lot of self-esteem issues, a lot of self-worth issues, and all of these issues just started kind of piling up for me. And it made it that much more easier for me to seek that comfortability somewhere else. And for me, that was drugs and alcohol. So just touching on things that are everyday issues. I mean, these are things that are hardly spoken about. How to deal with stress management. All those issues, they're extremely important, and I feel like they're not talked about enough.
So not like labeling, not having to have a mental health disorder or a substance use disorder, and way to talk about all of the things that everybody goes through as a human being.
Exactly. Right.
I think just acceptance and communication. It shouldn't be a dirty secret. Oh, that kid has a mental health diagnosis. That kid he was put away for substance abuse. Well, honey, my kid was with your kid. We're all in the same group. Like just because my kid got better, your kid was there too. So quit making it a stigma. Quit making it a dirty secret. Let's just address it. Let's accept it. Let's move on. It shouldn't be a fight to get a kid with a substance abuse a 504. With a mental health diagnosis, I mean, there's an ED called stop. Let's not make the other students scared because Johnny has a meltdown. Let's just deal with it and move on.
What about youth mental health first aid? Any of you using it, not just in schools, but among first responders and others who come into contact with young people at the moment they're experiencing a crisis? Okay. It's a wonderful program and a wonderful opportunity for you to bring to your schools, to your justice system, to your law enforcement officers, to your emergency rooms, to your emergency medical technicians, the EMTs. Youth mental health first aid allows them to begin to identify the first signs of a mental health or substance use disorder and teaches them where to look and how to partner with your agencies in order to get these young people to the right place and the right kind of help they need instead of having them end up in detention or in jail or in hospitals or other places that they may not need. So that's been very helpful in schools.
So we talked a lot about family and youth-driven services. What do you see as the best strategies for making sure you are driving your own care as full partners in planning and delivering services?
So I know for me personally, just working in the field of prevention, a big strategy of mine is just being comfortable with meeting someone where they're at. There's no finish line to this, to self-improvement, to lifelong recovery, to finding your own self-identity. It's not something that you have to rush towards. And that's one thing that personally worked for me, is allowing time to take time. That was probably the best thing that I could have done for myself. And also just being okay with getting honest, like I was touching on earlier, and not being afraid to walk through that fear. We're all human, and it's easier to walk around that fear, to beat around the bush with it, but to actually walk through it is a really beautiful thing. And I try to do just that with others. And also just creating an all-inclusive environment for people. And that includes me getting educated on what recovery looks like overall. Not just the type of recovery that works for me, or that I think may be best for an individual, because at the end of the day, my opinions and my personal perspectives, they don't have room in what I'm trying to do for somebody, and that's getting them on the road towards self-improvement. And what that looks like for me is just sitting down and asking them overall what they want in life, what they want to work towards, not what somebody else wants, not what someone else's expectations are of them. Really trying to find that self-identity, I think, is really important.
I believe that you need to meet the family where they are. Throwing services and things at them is not always the best for them. You need to find out what services they want is appropriate for their family. Our family, they kept throwing family counseling at us. If we try to get two 16-year-olds to sit in family counseling and talk, it is a waste of an hour. It is a waste of an hour. There's no point, but then we were not following through with the case plan. We were not meeting goals. Well, I can take two 16-year-olds. If I can only get one of them out of the car, that's all I can do. If I have another one sitting in the parking lot, hey, I tried. But now you're going to come back next week and say, well, Dana, we gave you this service. Well, that's fantastic. In our county, our school shut down for the week of the fair. You want my kids to do anything that week? It's not going to happen. So understand what you're working with, what our family's true needs are, and don't just throw services at me and then tell me I'm non-compliant or I'm resistant. You need to ask my family. You need to ask my kids. Ask my 16-year-old son, are you going to do family counseling with your sister? He's going to say no. Are they going to go out in the backyard and get the heck out of each other? Absolutely. Are they going to be good after that? Yeah. I mean, that's how they work things out. The family counseling was not a good thing. Besides, we had to drive an hour and a half to get there. Just meet us where we're at and what we need. And listen, when we say that's not going to work, that's not appropriate, don't keep shoving it down my throat.
Yeah, I think as service providers, we have to tap into their own creativity, and listen, and instead of labeling it as resistance, hearing it as feedback, and asking, okay, with all of my professional knowledge, what can I provide this family? How can I reach this kid who doesn't want to sit in a room maybe with his sister and talk it out? Maybe we all need to go do some experiential something or other so that there's a buffer and the issue will come out that way.
Don't just make it a checklist where we offer you these services on partnership app. We put a referral in. Who cares if it's 102 days, we gave you the referral, but do you want us to do it?
Right, and we've seen too often when it's in a service plan includes a few services that are based on what's out there, what's available. And that may not be what a family and a youth need. So asking them what they need and asking them to set their own goals and then looking at what needs to be pulled together to address those is really critical in terms of your engagement with services and the kinds of outcomes that you're looking for. I want to ask this question from a different perspective. We talked about, this is at the service level. What about the system level? It's important to have family and youth voice at the system level, as I mentioned before, in decision making. And we know that youth and family organizations play a significant role. What are some effective strategies for informing that, for ensuring that family and youth voice is part of the system level process? Dana, can you start? And then Matt.
Yeah, I would say bring youth and family voice to the table at the beginning of the process. Don't make them an afterthought, don't make them a token, don't just make them lip service. Honestly, bring them in at the beginning. If you guys are arguing about when is an appropriate time to bring them in, it's probably too late. It needs to be happening from the start, because they're the ones that you're going to have to apply. You can come up with a great plan, but if it's not going to work for a family or youth, then we wasted everybody's time. So bring them in from the start and don't just give them lip service. Honestly, listen to what they have to say.
I'm going to say, for me, and my personal opinion for this would be youth move, because for two reasons. Number one, we have accounting boards, and then we have state. And really, the more you tie each youth together, the more you're going to have a better chance at helping all the youth that you can. So it's really a matter of using your local county boards to start those, whether it's youth move boards through Family and Children First or through another outreach program. The Youth Move does provide trainings that can provide leadership trainings for the youth that teaches them to be able to step up and ask for that help and teach them how and to advocate on behalf of the others that don't quite know how yet. And if you really want to know what they're going through and what their opinion is, and if they can't say it, their best way is to talk to somebody else.
Thank you, that's great. And Dana, I know you're involved with Parent Advocacy Connections. It's part of NAMI Ohio, so you should share some thoughts, if you would, on that.
Again, like I said, bring your families in from the start. Know what families you want. It shouldn't be an argument, well, is this family going to be a DYS family? Is this family going to be a DE family? Like I said, if you're arguing about when to bring them in, it's already too late. Have them come in from the start, and don't just have them be the token parent that you just want to sit there. If you're going to bring them in, honestly listen to their opinions.
Yeah, and many communities and states provide contracts to family organizations at the state level and the communities and to youth move to support their involvement at the policy level. We all get paid. We have jobs that pay us to sit in on those kinds of meetings and in those deliberations when parent and youth volunteers cannot. So contracts and payment for their participation often is an equitable and effective way to facilitate involvement in that. We have one more question and maybe a couple minutes for a few questions from you after that.
Yes, so I think in closing, could each of you provide us a little message that you would like to make sure that the providers that are here today hear and can kind of leave with straight from the mouths of people who have been in these services, who are still utilizing these services, and maybe even will continue to work or participate in these services?
I want to just say streamline the process, streamline the referral. Every system I go to, I have to do a new referral. Every time I meet somebody new, I have to tell my story again. It's the same thing. We spend the first 3 meetings doing the same thing that I just did 3 weeks ago. We're doing assessment after assessment after assessment. If we're all doing the same assessment, let's share them. Like, let's move on with our stuff. I should not have to start over every provider, every new person, every new system. Let's work together, let's streamline the processes, and let's get the services rolling faster.
I would say use the communication that you have with your local boards and the other service providers that are there, and accept that there's youth out there and listen to them, because ultimately they're the ones that someday will eventually follow in your shoes or someone else's. And the only way to ensure that they get the help that they need and the future youth do, and that you fulfill your jobs and your life goals, is to really push for those youth to be able to step up.
A big thing that I would really touch on is kind of just reiterating what Allie was talking about earlier with her presentation, and in regards to just knowing that we're all on the same team and not being afraid to share information like she was saying, and knowing that what that does ultimately for a person is creating a separate support system, or maybe their only support system outside of that family dynamic, outside of that home. And that can definitely do a great deal for somebody. And, stepping outside those initial parameters of what you may think you're supposed to provide somebody with, and try to get creative with, new ways to help somebody. Because it's never going to hurt to learn something new, and it's never going to hurt to teach someone something new. So.
My background's in healthcare, and I know from experience that when I collaborate with other members of the healthcare team or other referrals, that there's not only am I providing more holistic care, but there's better outcomes for the patients. So I think if we can all add collaborator to the end of our job title, I think we'd see a lot better outcomes for a lot of the youth.
And I wanted to add also that I think this was great as far as an opportunity for sharing your perspectives about how we can improve as clinicians, as systems, but also for sharing so much about yourselves, which I think takes courage, and we are very appreciative of that.